Thank you for joining this morning, and I'm very pleased to welcome our two guest speakers, Dr. Ann Cornell and Dr. Mike Privitera. Today's topic will be on well-being and burnout prevention during COVID-19 and beyond. And I'm very grateful to both Ann and Mike for pulling this presentation on such short notice, just 1 week notice. So greatly appreciated you joining us early this morning like that. Thank you also to Beth McNeil pulling all this information together. And this session will be recorded. And thank you, Jim Lachase for coordinating this, and it will be posted on our intranet. A couple words about our speaker. We sent a more extended mini bio. Dr. Michael Privitera is professor of psychiatry and director of the URMC Medical Faculty and Clinician Wellness Program. And Dr. Ann Cornell is assistant professor of psychiatry and director of the employer-based services. Both have been instrumental in changing the culture, helping our employee and staff and faculty for issues related to well-being and burnout prevention among faculty and staff. I personally have had the privilege of working closely with Mike, and I can attest to how many wonderful initiatives he's implemented around the institution, and as well as changing our culture to support our faculty and staff. So thank you so much, Mike and Ann. Just a few things before I turn it over to you. Please make sure your mic is muted. But of course, when it's time to ask question, unmute yourself. And for the question, I'll also be monitoring the chat box. So feel free to post question on the chat box. And as I mentioned again, this session will be recorded. So thank you again all for joining, and I'll turn it over to, I believe, Mike, you're going first.
Yeah, I'll start it off. Thanks, Janine. Thanks very much. Well, it is a pleasure to be here. I appreciate actually the invitation anytime we can get to be able to talk with different departments and all. That's great. This is very important information that has been before, and it's even more important now, as we all can probably attest. So some of the things we're going to do is talk a little bit about what we've been able to learn from Italy and China, some of the ideas, how we kind of extra ways of stepping up to kind of help each other, checking in with each other, and then a little bit of the ways to try to get out of work as much, to be efficient, get out and try to get home to rest, because we got to take extra good care of ourselves. And then Ann is going to be talking about the great resources that she and her staff provide to try to help us with this, both for EAP and BHP, and a little bit about psychological first stage is what it's called. Okay. Learning objectives describe different phases of emotional responses during the pandemic, and appreciating the available institution EAP and BHP sources, and then identifying the skills needed to take care for ourselves. And you can see the planning committee and presenter declarations, no disclosures to make. And this is accreditation certification statements, no commercial funding. Okay, so this was a really timely publication that came out about minding healthcare workers, the psychological responses of healthcare workers during the COVID pandemic. And they've kind of learned a lot from other national issues that have happened that are tragic, disasters, and so on. But pre-disaster, then the impact, then the heroic phase, like we're hearing a lot about that in the media, right? Hero is trying to help us all. And then the honeymoon phase, disillusionment, some of the things that might happen. You're just trying to put up with things and trying to get through it, as well as the media changes a little bit, some of their stories. And then getting more into the reconstruction phase. So just to kind of realize there are ups and downs to this, you probably anticipated that this has actually been looked at, so it helps. Just kind of this mental health consequences of COVID. 60 Minutes had a program on, I think it was April 12th, about calling the mental health consequences a second pandemic, just because it's the impact on us as humans is to be expected, and let's prepare for it, and let's try to do what we can to mitigate this, just like we mitigate infections. So sudden changes in national day-to-day behavior, social distancing, and their favorite businesses shut down. And the SARS epidemic showed increased stress, PTSD, psychological distress in both patients and clinicians. So that's the point why we're here. Mental health and well-being consequences anticipated are short-term and long-term that they've noticed. So we're about trying to prevent that as much as we can. Large-scale disasters that have been studied, depression, PTSD, substance use, because of the stay-at-home orders and stuff. When there's tense situations, there's more risk of domestic violence and child abuse. So those are things that we have to weigh, the issues about staying home versus a safe place for people. So there's inevitability of loneliness. So we connect virtually like we are now, instead of in-place grand rounds. We're connecting with each other, trying to still connect with people. So it's physical distancing, not really social distancing. Getting routines are important as much as you can even though you may be working from home, how do you keep that into some kind of routine? How do we kind of keep track of each other, how we're doing, and when it might be interventions? So social distancing versus a safe place. So to some degree, there's judgment about when it's time to get out of the home, do other things, be in a safer place for your own mental health or physical health, as we talked about. So what's recommended is, it's called stepped care, the least resource heavy to the person's in need, then you move up in terms of more resource heavy treatment. And so there's more of a issue of training non-traditional groups to provide psychological first aid. So Anna is going to get into that in more detail, so I wanted to save that for her. And teaching colleagues to check in with one another and provide support. These are times we can help each other. Checking in, even that, the check-in that you cared makes a difference. So this is some of the information from China, came out March 23. So physicians and nurses in a hospital, they called fever clinics or wards, patients with COVID-19. Healthcare workers responding to the spread reported high rates of depression, anxiety, insomnia, and distress. So protecting healthcare workers is an important component of public health measures in helping us, which helps the patients. So looking at this as a public health intervention. The special interventions, they found especially women, nurses, frontline workers requiring particular attention. So we'll talk about some of the things that I know that Mike Apostolakis is already trying to help with, and Karen Davis in nursing. Priorities during the pandemic. First, very at the top, the PPE we need, adequate training about infection and keeping from transmitting infections. Trust in senior management and issues of leadership are really key right now. The AMA came out with a wonderful paper about advising hospital leadership about how to work with this and what is best to do. So there's kind of a blueprint to it that's at least they've worked on with two of the chief wellness officers, one at Stanford, one at Mount Sinai, who should know a lot about what's happened with the COVID outbreak. Physiological, emotional well-being, and then works feeling meaningful. So top priorities during the impact and heroic phases. Trying to, emotional well-being and connectedness, priority through the journey, but sometimes they get sacrificed, but we have to catch up to doing it. And the work feeling meaningful, especially heroic phase, it may erode a little bit in disillusion phase, so we got to watch for that. Building connections that sustain family and friends, colleagues as individuals, So there's colleagues as teams and as individuals, and then specific therapeutics would be like EAP, BHP, and other more direct one-on-one. So from family and friends, comforting feedback. If you're more distant because you had to be separate or isolate yourself in the home because of your direct contact, letting you know you'll be back and reminding them of that, and other ways you can connect. Basic needs are there. Teams are really important, thinking and feeling together, shared decision making, including well-being checks on each other, individual relationships with colleagues, being together, actually meaningful experiences, sometimes sharing perspective, sharing stories is actually quite helpful. And then a safe place for having a place to talk, feeling the burdening, unloading that, meaning preventing long-term fallout. These are some of the recommendations that came from a meta-analysis that they did very quickly about all the papers that are out there. What's the literature say about dealing with this? Healthcare workers with novel outbreaks. So the kind of a buddy system, encouragement, trying to keep positive through this. Some of this isn't rocket science, but it sure is important to remember and bring it up and try to use it. Communication and training. What is the proper education about infectious diseases, control? Janine's going to be able to share all these slides, so there may be a lot of small print, but you'll be able to see them more close up. Psychological recognition of staff efforts, what people did well during this time. Access to psychological interventions, workload issues like especially shifts. We know that the overwork, your defenses start going down. You're working extra long shifts, if you start going into doubles and all that kind of things, coming back with less sleep. We got to be careful with that. We need the recharge more than ever. And then attention to how the media is portraying things. And, we're lucky about the sides of being heroes instead of being concerned about people that we might infect other people in society. So the stigma and discrimination issues. So point I'd like to make, how do we get done and get out? Because what can we do to be more efficient, to get the work done, get home, get out of the hospital, just to save the intensity and the prolonged nature of the duress that happens. We're facing things nobody has ever faced before in our lifetime. So how do we take good care of ourselves is the point. A way of looking at it is neural resource or brain power, and how you can optimize that to get efficiently done and out is the point. What happens with interruptions in clinical work? It's called an attentional blank. You lose 640 milliseconds of data that's gone forever, that you don't catch it right after an interruption. And then if you're really trying to get back deeply into what you're doing, it takes 23 minutes to get really well focused again, which causes the stress, frustration, time effort. So how can you minimize these interruptions as much as you can? Some have to occur. Like in this study, they looked at same context interruption, had something to do with what people are working on together versus different context. Point is stress, frustration, time pressure, and effort goes up. The greater number of interruptions, the longer it takes. So if you can look at this graph here, no interruptions, 1 interruption, 2 and 3, trying to do the same task takes longer. A big thing that we can do something about it, a brain drain, is our own smartphone reduces our cognitive capacity. So if it's right on the desk next to you versus being put in a bag, like you're someplace where you're not looking at it, but it's still near you versus another room, your working memory goes up the further away it is from you, because it kind of pulls you into the constant nature of what might be on there. And your what's called fluid intelligence goes up if you keep it away from you. So there's a balance here, but just to realize this is what happens when we're constantly near our smartphones. And constant emailing and texting, it reduces the mental capacity to average 10 points by IQ. So we want to be smart. We need our IQ, right? equivalent to loss of night's sleep. It's an artificial sense of constant crisis. So how do we minimize that? So we can use our brain power to get out. Vigilance can be improved if you can reduce work hours. Rest breaks, they're actually really important instead of continuing, if you have the option. I know a lot of you guys are in a continuous procedure, not much you can do about getting away from that, but when you're doing other things, if it's notes, whatever, breaks are important. And they're recommended 15 minutes every 2 hours. What it does is it really recharges your attention and your efficacy. And it's more important than we let on. Napping, if you can possibly do that, it increases the IQ by 10 points compared to the fatigue state. Cues, something's coming up. Is there a way to set an alarm or something to make you more aware? Telling yourself how much time you're going to give this task for end pressure. Standing desk, I know neurology is really good at this, and on their wards they have standing desks where they do their notes and stuff. 42% more productivity, those who stand. Motion, if you've been sitting and trying to do your work, try to get up, engage your body, move around, and then try to do the work. Changing your environment helps. If you're doing your notes one place and just picking up, doing them somewhere else if you can, that helps. Walks when you can. It's something really special about nature, trees, shrubs, water, that's a recharge. Brain extenders is, well, you hear it's going to rain tomorrow, so when you know that, put the umbrella near the door then, instead of having to use more brain power to kind of remember the next day. So these are just ways of saving it. Productivity hours, managing interruptions. This is the key issue about productivity hours. If you, as much as you can, fully into one activity or another, trying to set aside time when you can, not to be interrupted. If you don't be bothered by emails as much, one at a time, try to batch them and just say a couple times a day that these are the times you're going to do your emails. Try to turn off your phone when you can. And any ways messages can be taken if you have that luxury in certain settings. I wanted to just kind of let you know what goes on with this, our medical faculty and clinician wellness program, because I don't think the whole story comes out sometimes. You can bifurcate it into administrative interventions and work, and then education. I work very closely, as you know, and the privilege of working with Janine. She's been helping this message get out, and I really appreciate what she's done for all of us by helping that. So she and I have 2 sets of seminars together, our monthly wellness seminar series, and sometimes I know that people can't get to them. We try to record them, but I know that's not the same. And then we have, this is the second year for what we call human factors-based leadership seminar series, which is people, different levels of leadership in the hospital that have been coming to the seminar series. And a couple people took a project, they're going to present it in June. And it basically kind of works on kind of the neurocognitive issues to be aware of how you can lead people better, to be able to mitigate the bad experiences that people go through based on human factors. So it's a legitimate science. We don't use it enough in healthcare, and it's kind of time we should. The Wellness Strategic Planning Work Group, I chair that. It's kind of it started off as looking at all the suggestions that came out of a 2015 survey that was done with medicine, surgery, and psychiatry, and all these write-in responses. We did an impact versus feasibility study, and then had 4 waves of rolling out interventions. Now we have Department of Wellness representatives. For anesthesia, it's Jennifer McPherson, and we have them for different departments. They're for most departments except 2. There's an MD and an APP. Now we have nursing. Mike Apostolakis is part of this meeting, Vicki Hines and Kara Halstead from URMFG. So we work at the hospital level, workflow issues and occupational stressors. One of the things that we think has given us more hope, because there's never ending set of mandatories, is we got to take charge of that. We got to know the total, put them all in one place. Do they really need to be mandatory? Are there things we can take away? Do we have to use that software that is slowing us up? that takes forever to go from one slide to another, et cetera. So we're working on all that. We have the management council together, and we've met 4 or 5 times. So things are moving. I just want to let you know it's moving. We're trying to get in the right direction. Dr. Taubman has signed off on this as an advisory group. So we're trying to work closely with content and the experts in content. We also have presence in ClinOps, Provider Advisory Council, which is a lot of workflows in EMR, Medical Executive Committee, and Total Worker Health, which is a federal initiative about looking at not only the health after whether or not there's illness, but how can we prevent it? How do we keep psychological well-being there as well? And then collaborating with Anne and her group, EAP, BHP, WellU, and there was a COVID staff support task force that I wanted to show you where the resources are. So there's a whole cluster of different COVID-19 contact numbers, but this is the one that a group of us put together and collaborated with all parts of the institution and try to have a two-way communication so that we work together as a group to try to help staff at all different levels and resources. So now it's operating 7 to 5 Monday to Friday, and it's continuing. So if people are calling and they need a higher level, we can provide that of help. These are the results so far. Left-hand side, caller locations and employers, a lot of it being strong. Highland, University of Rochester itself, 9%, and unknown, because we make it, it's optional to say where you're working, what your name is, so we try to keep the anonymity if people want that. Who's calling? Employee, 72%. Family members of employees, 6%. And they're calling about the employee, family member, unknown. But really interesting, at least to me, is only 19% of the calls were for emotional support alone. Information and resources was 50%, and then the combination was 31%. So where can you find this? A lot of times you see Mike Apostolakis' emails that are summary about what's going on in COVID. So there's the intranet portal. So I put in red there, that's where it is. And it refers to emotional support resources hotline. That's the phone number, but getting in through the portal. Sometimes if you don't have his email, how do you get there? So that's what I wanted for people that may not have the email. It's a little more a series of maneuvers, I guess the way to put it, of how you get there. Through the intranet, you go up to department sects, click 1. Click 2 is at the intranet infection prevention. Click 3 is under infection prevention, you go to public health information. Click 4 is the intranet portal. 5 is the intranet portal that talks about emotional support resources. Our new site is an active link. And this is what it looks like when you land on that page. So it's divided in emotional support information and resources, personal wellness information and resources, and then general information like finances, food, housing, childcare, basic human need issues, trying to help people when that comes up. Some people have to temporarily not live at home, for example, and trying to provide a place for them, and physical health and things like that. So I think just wanted to make sure that you know how to access this information. So I went kind of quickly here, but hopefully the overview, and Anne's is going to be more in terms of helping us to learn what are the kinds of things that we can do more. So that do have a few minutes here for any questions and any discussion.
Thank you, Mike. I guess I'll start with a question here. With all those calls that have been triaged, you mentioned the type, whether it was asking for support or emotional support or just informational resources questions. Had there been any sense about different groups, what their issues might be, whether it's staff, faculty, student versus faculty, etc.?
Yeah, that is very interesting, and that is being looked at by Tony Sexton and George Nasra. And I'm not sure if Ann knows when she starts presenting the breakdown from there, because they are trying to, if the person lets them know where they're working and whether they're faculty, resident, or other medical student, other staff member, if they tell them, because we want to make sure it's optional. But they are looking at that, and I don't have the information yet.
Mike, I can tell you because I'm on the calls a couple times a week for them, and I also volunteer for the line and have taken a few calls. So we're seeing a lot of themes of people that are on the front lines, but usually in facilities or transport that are calling us, or nursing staff, or even physicians that are calling us. Some of the general themes are people feeling angry about not having the right equipment, or not feeling as though they don't have the right information to stay safe. I've taken a couple calls myself with people in transport and facilities saying we walk into a room, we're told it's COVID negative, we walk past it the next day, all the signs are up, it's COVID positive, and I just went home to try to, stay awake all day and work all night and take care of kids. So we're getting a lot of questions about risk of exposure and keeping safe, and then how to go home and then keep family members safe has been my experience. And there's definitely seems to be some themes with the questions that we're getting.
Is there a good resource you're able to give people then at that time?
We are. We have a mass collection of resources that those of us volunteering on the line have access to. And then on the EAP website or the BHP website, if you Google BHPURMC, second tab, really easy to get to, says COVID support resources. And that's where we've massed any resource that comes my way that I think is legitimate. We've got it broken down by different sections like kids, emotional support, relaxation, meditation, housing resources. So that's often a link that I'll open up, and it's really easy for any of you to pull that up again on the EAP LifeWorks Connection main page. It's right there, second tab, or the BHP website.
Thanks, Ann.
Yeah.
One thing we've had to use in our outpatients is the infection control nurse for questions. And so for employee questions about infection, we've had people that have had contacts with somebody else and they're coming in. What do we do? How do we handle it? So the infection control nurse is at least another resource. Okay. Anyone else? Okay. Ann?
Sure. Okay. So similarly to Mike's format, I've been trying to come up with a few interventions that I can talk to people about. They're evidence-based. We know that they work. They've been around for a long time. I'm not going to go through all the research and why they work with you, just due to time constraints, but I wanted to come up with at least 3 briefer types of interventions that would help you know what you can do in this time of crisis, and also for others, and then what you can do to help yourselves. So some of you probably recognize me. I know I work with the anesthesiology department to onboard all the residents, and I come and meet with you every year at some point. Some of these you might have heard of, at least one particular one. So we'll talk about that one again. But again, I just want to make sure that you have the tools that you need during this time. I am going to read my slides a little bit more than I typically do, because I can see here that some people are just on the phone line. So let's see. Nika, it sounds like let me mute you if I can, just so we're not all hearing. Okay, so the first thing I want to talk to you about is psychological first aid. Through the Employee Assistance Program, this is what we do when someone comes to us in crisis. It's not the time for psychotherapy. It's not the time for medication necessarily. It's a time for what we call psychological first aid. So psychological first aid is an evidence-informed approach that's built on the concept of human resilience. PFA aims to reduce stress symptoms and to assist in a healthy recovery following a traumatic event. It could be a natural disaster, a public health emergency, or even a personal crisis. So what we're facing now is that typically in the immediate aftermath, when we talk about that, that means that we try to get out to support people within 48, 72 hours of an event. What we're finding now is with COVID is that we're not even in the aftermath stage yet. We might be getting there over the next couple of weeks or months, but then we might see another surgence. So we're really still in this very prolonged crisis phase. So people are experiencing the psychological and physiological impact of this stress response. Next slide, Mike. Thanks. So this isn't going to surprise any of you. But our common stress reactions can be pretty varied. So just as a physical first aid is used to reduce physical discomfort, bodily injury, etc., psychological first aid is a strategy to reduce the painful range of emotions that people experience when they're exposed to high levels of stress. And I'm imagining that you guys could look through this and probably have felt most of these. I don't know any professionals or anyone that I've interacted with over the past 2 months that hasn't said that they feel like they're on a little bit of a roller coaster, like they're in the car, but emotions are coming and going more often than normal. So confusion, fear, feelings of hopelessness and helplessness, sleep problems, physical pain, anxiety, anger, grief, shock, aggressiveness, withdrawal, guilt, shaken religious faith, loss of confidence in self or others. These are all really common stress reactions, and I'm highlighting them just because we know that one of the most important things is being able to recognize how you feel and to normalize that. So whether it's for yourself or a colleague or someone on a team or someone that walks out of the OR with you after a long surgery, being able to normalize these emotions is really important, because when we don't, people can start to get into a cognitive process where they're blaming themselves. I should be able to handle this. I don't know why I'm feeling this stress. There's something wrong with me. And we know that that can create a fracture and can cause more trouble. Next slide. So a lot of us are pretty familiar with Maslow's hierarchy of needs. When we talk about psychological first aid, the first thing that you're really making sure of actually is safety. So when we talk about that, when we're at a crisis situation for psychological first aid, it might be making sure that you are not near a crumbling building if there's been an earthquake. For us, it's a little bit different here. So the International Federation of Red Cross and Red Crescent Societies published interim guidance for providing psychological first aid remotely during the COVID-19 outbreak. So providing PFA in response to COVID-19 looks different than it would if we were responding to something like an earthquake or a tornado, because we're trying to practice social distancing. So this first bullet of safety has different implications. We're not talking about encouraging someone to sit away from the rubble, but we're asking them, are you in a safe environment? Do you have a home that you can return to? Are you in a hotel? Are you in the hospital? Can you step away? Do you have, the equipment that you need to feel safe? Psychological first aid is not a very, very complicated process, but again, being anchored to the very basics of it can help you know that you're actually doing something in that moment, that this is evidence-based and it's enough. It doesn't have to be a huge intervention. So I want to review with you the basic 3 actionable principles. Next slide, Mike. Thank you. So this is look, listen, and link. And for all of you, this is going to sound really familiar to what you do when you arrive in an emergency situation, except for the link part. So the look part is about a needs assessment of a current situation. So again, this could be a colleague that you're talking to. It could be home with a family member that you're trying to figure out what's going on for them, or it could be somebody on one of your teams. So the practical and emotional support component of this is the person affected by worries. Is there violence in their home setting or at work? Fear of losing their livelihood is something that's been coming up a lot lately, specifically because we know I think it's about 18% of all university employees that are facing full or partial furloughs. The fear of losing friends to COVID, family hospitalizations, being distanced for many reasons, or not even being able to visit family members. The current situation of the person. Are they in lockdown and isolation? Are they in quarantine? Are they a physician or a nurse that's been sent home to stay healthy? So being home, trying to stay away from the front line to be called back in as needed can be really stressful too. Or they with family, are they not? We work with a lot of residents and physicians or interns that are really struggling because their family's in California and they can't go visit them. And then also, is this imagined or realistic risks that the person's experiencing? So fearing infecting others, even though they're not showing symptoms, afraid of infecting others who may need their support on a daily basis. So that's the look component. The listen component. You guys are so well trained in this, and I almost took it out, but it's really important to remember, especially when there's so much going on. We have to do the basic components that we know that work when we're communicating with somebody. And that really means beginning the conversation or even introducing yourself. Who are you? Why are you there? What's the role? Paying attention and listening actively. One of the things that I've noticed that I found somewhat surprising, even though I shouldn't in my field, is how differently this is impacting everyone. And when you really listen, there's truly different parts of this global pandemic that we're experiencing that are triggering anxiety or stress responses in different people. And if we don't listen actively, we're really likely to assume that someone's feeling stressed because of the same reasons that we are. So we need to ask people about their needs and their concerns. As I said before, we've got to normalize feelings, helping to calm down the stress, and help them find solutions to their needs and problems. As Mike commented on, particularly with the support line, we're getting a lot of questions, especially initially of, my employer told me to call you, I have a fever. And I'm thinking, that's really not us, that's not the right line, but we can get you the resource, we can get you the right phone number. Or if people are asking me, I don't know the ins and outs of infection, do I have to put a mask on, gloves, do I need a face shield? I stay up to date on the alerts that we're all getting or the updates, but it is not my role to give that guidance. So I help people clarify what their specific question is, and then where do they go to get that answer from their department or from infection control. And that pulls into this link part, is really helping people get connected to resources, but also for psychological first aid. A big thing that we do, whether it's we're responding to RPD after a critical incident or anything COVID related, helping people think about their natural resiliency. And we know that people need to connect with loved ones and supports. People, all of you and everyone are coming up with some amazing ways to stay connected despite this. I'm one of 36 cousins in my family, and the family Zoom meetings are highly entertaining, although completely non-productive. You have no idea who's talking or what's going on. But it's been a really neat way to stay connected and at least to see each other. So people are coming up with some really creative ways to do this. And in that moment, you might need to help someone and say, when's the last time you talked to somebody from home? Is there a new routine that you can establish? How are people connecting? Or even helping people tackle what is the problem. So those are the main principles of psychological first aid. And in your mind, if someone's distressed and you can say, all right, I need to listen, I need to look, and I need to help link this person, that really is an effective intervention. And it really is enough in that moment. It's not the time for some more complex, higher level intervention. Generally, people aren't in the state cognitively where that's going to be helpful anyway. So that's like coming off of 2 shifts in a row and somebody wanting to sit down and plan a really important paper or a grant that you're going to write. It's not the right time, as Dr. Privitera was talking about. It's the time to really connect with what are your needs in that moment. Okay. All right. Next slide, please. Okay. So we talked a little bit about how this is making everyone that's calling us feel, but I also want to share with you what we're hearing from you guys, what we're hearing from medical professionals about how you're all feeling. And this comes from our work at the EAP, the Employee Assistance Program, but also at Behavioral Health Partners, as well as on that support line. So number one, people are feeling really anxious. And even though more information's coming out, and I think the information's been more consistent, and I think we all have more access to protective equipment, people are feeling really anxious and very often about risk to self and family and how to keep yourself, but even more often how to keep your family safe during this time. We're also feeling a lot of anxiety about job stability. And even areas, such as our own services where we think we have general job stability. I get questions at least once a day from team members still, am I going to lose my job, and am I going to be furloughed? What's going to happen? So it really impacts the university through every rank and profession. People are feeling really overwhelmed. We've been doing this for about, I think, 8 weeks now in general. I've had team members, I'm the only one at work. I've had team members home for 7 or 8 weeks solid. And the things that are overwhelming them are fluctuating based on, are they at home trying to manage technology and isolation? Are they at home and trying to manage Seesaw or other apps that we use to try to keep our kids' brains working during this time? Or are there other responsibilities, changing shift schedules, or are they overwhelmed and anxious because they don't even have somebody watch their kids with shifts that are and demands that are changing? We're hearing a lot about anger and resentment. This came in a wave about 3 weeks ago, and it's quieted, and I think we're going to start hearing it again just as things fluctuate. Initially, it was in response to unclear and inconsistent communication and lack of adequate PPE supplies, and assumed unrealistic expectations, and people calling us to say, you know, I was told I'm going to get fired if I don't go clean that room, or I was told I'm going to get fired if I don't accept, you know, being, you know, reassigned to this different unit. And that can build anger and resentment. As I said, I think that's quieted over the past 2 weeks, and we're seeing people just feeling more overwhelmed and anxious and fatigued. As we get into this, we are hearing more about moral distress, which is a topic I know you are all familiar with, but that happens when we are asked to do something and to take, or we asked, or when we are asked and feel that the ethically correct action for us to take is different than what we're actually being asked to do by the system. There is a moral distress team and an email hotline that's working really hard to address this. But it's a really challenging situation that we're in, particularly, I think, especially in the initial stages when we had no family, even in palliative care, that we found ourselves in some pretty difficult situations. Grief is a huge one. We don't have the conventional rituals that would normally help us cope. Team huddles are now virtual if they're happening. There are losses that are accumulating for all of us, and I think those losses are going to be different, and we barely even know in some ways what the long-term losses are going to be. But that can be, you know, losses that you're experiencing on behalf of kids that are losing the rest of their school year and their friends and their routine. It can be losses that we're experiencing because of the loss of loved ones. It's loss of that social connection. My parents are in their 70s. I haven't seen them in months. I see them over Zoom, but there's no plans to go visit them because I'm at work every day and I wouldn't want to risk them in that way. So there's the cumulative losses over time of missed birthdays, missed families, events, and then also missing our team members, as a lot of us are reassigned to different places or not seeing each other on a daily basis. And then I'm hearing from, you know, physician, nurses, all medical staff, any other emotion you can possibly think of, and they're all fine. But confusion, afraid, loneliness, sad, they're all fair game, and they're all really normal at this stage. Okay, next slide. So one of the points that I want to make, and this works for physicians, it works for therapists, it works for everyone, is that knowing is not the same as doing. I have no doubt that any of you, if we said, hey, we need you to give an hour-long presentation today on health and wellness, you could do it. We've heard enough lectures. We know burnout. We're tired of hearing about burnout. We know all the information is that we need to know, but that doesn't mean that we do it. And I always joke, and I can with this crew, we have fat cardiologists, right? We know Americans in general aren't that healthy. So we know that there's some real gaps in knowing and not doing. I love the things that the university is doing to support and to highlight the efforts that people are making. I also have some umbrage against this idea of the "you are hero," because it puts those of you that are in a position really of trying to help and take care of others and really wanting to step forward and being called to duty in this way. But you don't have to be a superhero in your own right. What we're finding is that we can be better superheroes when we're really working part of a cohesive team, when we're recognizing when we need to take care of ourselves and when we need to take a break. I think Dr. Privitera does a great job of helping us recognize just cognitively when we can't function as well. And for those of us that are more academically minded, I think that really actually helps fight some of the should statements about what we should do. Dr. Privitera told me once at an afternoon meeting on a Friday when I was jabbering and not making a lot of sense that after putting in 40 hours, we're down to about 35% of our brain capacity. So we canceled that meeting and I made a lot more sense on Monday. But because of the demands on us and because of our caseloads and because of what's going on right now, we are getting a ton of information. Daily, the regulations can be changing. Where you are assigned, schedules are changing, the extra burden of worrying about what's going on at home when that's not stable. Given all of that, none of us are actually performing at our optimal cognitive ability, but we're really asking ourselves to do more than usual. And I know that you're a group that's actually used to functioning that way, but it doesn't mean that you're a robot. So we do have to take care of ourselves. And I do think that all of the very wonderful attributes that make you good physicians or good medical professionals also contribute to making it really difficult to take care of yourself. So I've chosen 2 tried and true, well-researched ways that I want to review with you all briefly. If you've heard of 3 Good Things, or if you've heard of acceptance and commitment therapy, and you don't use these, I really want you to listen and ask, why am I not doing these? Particularly 3 Good Things takes about 5 minutes every day, and most of us can actually find 5 minutes, whether you're doing it in the shower or you're doing it while you're taking the dog for a walk. So most of us have the time to implement these really low demand interventions that have a high yield for their effect. But again, a lot of us don't do it. So if you've heard of it and not doing it, ask yourself why you're not. And if you haven't heard of it, please listen carefully. Okay, next slide, Mike. All right, so 3 Good Things. Many of you might be familiar with Martin Seligman's work and the practice of 3 Good Things. The practice of 3 Good Things is based on the fact that we're actually hardwired as humans to remember the negative things, and it's harder to remember the good things. You could go for a walk through nature and it could be gorgeous and beautiful. If something negative happens on that walk, you're not going to remember the pretty butterflies or the flower. You're going to remember that like a bear jumped out behind a tree, and you probably won't walk that way next time. Or if you do, you're going to have like a pocket full of change or whatever they recommend to keep yourself safe. We're hardwired for survival to remember the negative, and it's a lot harder to remember the good things. There is a way around it, and this study has shown that we can short circuit this effect. So we can build resilience even in the midst of a pandemic by focusing on 3 good things that happened that day and noting to yourself what you did to contribute to them happening. So next slide, please. Thanks. So the exercise is just before sleep or within the range of 2 hours before you go to sleep. Ask yourself the questions. What are 3 things that went well today? And what was my role in making it happen? These don't have to be earth-shattering. It could be, I actually got up this morning and went to work, and it was a struggle to get out of bed. I was tired. I didn't want to face the day, but I did it. And what was my role? I made it happen. And, I was able to help support patients, and overall, it was a pretty good day. It could be things that you don't do. And I've tricked my kids into doing this by telling them that they might not be able to do it, but I work with the physicians on it. So now, of course, with reverse psychology, they want to do it too, which is great. So it could be, 3 good things is you really were frustrated today and you didn't hit your brother in the head. I saw that you wanted to and you didn't, and that was great. What did you do to make that happen? So these are small things. They don't have to be big things. But we know that this is effective as a low-dose antidepressant if you do it for 14 days in a row. So something that could take you 3 to 5 minutes is as effective as a low-dose antidepressant. I always say this carefully. I don't want this to get stored in your mind in the way that all I have to do is think differently and I'm going to feel better. We know that depression is a disease and you can't just pull up your bootstraps. But we do also know that for residents and physicians and for all of us, if we pay attention to the way that we think, if we short circuit this before we go to bed at night, it can make a positive difference in our mood, in how fast we fall asleep, the quality of our sleep. Okay, so 3 good things. If you want to read more about it, it comes from Duke University Mid-Michigan Health System. Okay, next slide. The second intervention that I want to talk to you about, some of you might be familiar or you've read briefly about acceptance and commitment therapy. So we call this ACT. It's an evidence-based intervention that uses acceptance and mindfulness strategies. So the entire goal of this is to notice, accept, and embrace. So rather than trying to control everything, your thoughts, your feelings, and your sensations, ACT teaches you just to notice and accept them, even if they're unwanted or unpleasant. So it's based on acceptance, and it's based on values and meaning, and the practice of being present with life, with what life brings to us, so that you can move towards a valued behavior. I think we're all relying on this more, and all of us, in the psychology field and mental health turn to this very quickly because it's a wonderful model for something like COVID. There are real anxieties out there. We can't deny that. And a lot of the cognitive techniques or other strategies that we might all use that identify an irrational thought and challenge them, well, they don't work right now because those irrational thoughts might actually be a lot more rational than they typically would be. We haven't all just as a mass, humanity developed OCD in the past 8 weeks, but we all have OCD type behaviors that we're engaging in for some really good reasons. So acceptance and commitment therapy gives you a framework for what can you do in the moment to tolerate and to sit with, but also to be okay, even if you're not feeling well. Next slide, Mike. So Dr. Russ Harris, so he's the author of The Happiness Trap and works with acceptance and commitment therapy, quickly came out with this acronym that I think has been lovely. And it's really simple, which I think is great, especially when a lot of our brains are tired. So this works well for you. It works well for your family members. It works well for your patients and anybody that you're interacting with. So the acronym is FACE COVID. So I'll read it again, and then I'll talk about the different components. The F is for focusing on what's in your control. The A is acknowledging your thoughts and feelings. C is coming back into your own physical experience. E is engage in what you're doing in the moment. And then the COVID part is committed action, opening up, value-based, identifying resources, and of course, disinfect and distance. So focusing on what's in your control. As I said, anxiety and fear are absolutely inevitable in a normal, natural response to stressors, and it's easy to get lost in worry and rumination. We can't control the future, so the most useful thing that we can do is focus on what's our control, focusing on the here and now. There are a lot of things we can actually control. It could be getting out of bed in the morning, it could be going to work, it could be what we're eating some days, or if we're getting a little bit of exercise, it could be taking a break if you're having a more leisurely routine and you're not in the OR all day, like Dr. Privitera said, if you can get 15 minutes in every 2 hours. I used to close my door at the office to control during the day all of those constant interruptions, and I have to say one of the bonuses is nobody's here. So I've actually been a lot more productive than I typically am because I'm not getting bombarded by about 20 different case questions all day long. So focusing on the small things that are in our control. Acknowledging your thoughts and feelings is a huge step, and it often gets undermined or undernoticed. But typically, if you think about your interactions with someone that you care about, if you're able to sit down with them and share your thoughts and feelings, and they can respond in a non-judgmental way, that truly is one of the underlying components of why therapy works. So if you can do this with yourself, if you can acknowledge your own thoughts and feelings and try not to judge them and just sit with them, it really is a tremendous intervention and can be really helpful. I always think it's rather than kind of dragging something behind you and like a whole bunch of weights that you have to drag, if you can stop and kind of turn around and acknowledge them and sit with them, you're much more in control of them and they actually get smaller. Coming back into your own body is a grounding technique, noticing what you're feeling, what's going on, and remaining connected to your own physical actions, even if you can't control your feelings. You can control what your body's doing. You can move, you can walk, you can breathe. Engage in what you're doing. Using your senses in any experience. So even if you're in the OR and you're standing there, you can, because I've worked with you guys long enough, I know you can disconnect at times. You're waiting for the monitor to beep, you're monitoring things, but you might not need, all of your brain functioning to do that. You can call that into action if you need to. So engaging what you're doing physically, noting to yourself, what are the things that you can see? What are some things that you can hear? Are there any tastes? Are there smells? Are there sounds? Just coming back into your own body. Committed action. We all do better when we are doing actions that are guided by our own core values. So whether you're home and you're trying to find an activity to do, or you're at work, if you can connect on some level with why you're doing this and how does it fit in with your own values, which is the V component, we get more out of it, and it's more rewarding. The open up one is similar to acknowledging thoughts and feelings, but it's making room for difficult feelings and being kind to yourself. Values are, what sort of person do you want to be going through this? And this is something that I've been asking a lot of people that I'm working with. When this is all said and done, and we don't know when that's going to be, right? So it could be 6 months, it could be 18 months, it could be 9 months, we're not sure. But when this is all said and done, what do you want to be able to say about yourself, how you acted, and what you did or what you focused on during this time? I think this is a lot more important than the should statements that I'm hearing from everybody. I should be exercising, I should be eating healthy, I should be able to focus, I should be able to taking care of patients, I should have been able to figure this out. And my counter to these is I didn't personally give a lot of thought before this as to how I would behave or what I should be doing during a pandemic. So I kind of doubt everybody else did. And if you did, we probably diagnosed you with something, if you thought that far and that anxiously in advance. But we're here now. So really trying to figure out what kind of person do you want to be? And that's different than how, every moment of every day, but how do you want to act and how can you come back to that? Identifying resources is huge. And again, our website can be really helpful with that. And then disinfect and distance, which you guys are well aware of. So next slide. One step at a time is really important. These are all really basic things: eating, sleeping, drinking, staying active, maintaining your social connections, setting boundaries, unplugging from work, all of the things that we've been talking about, but they can be really difficult to do too. And when things start to not go well or you're not feeling well, we do have to go back to the basics and to see which one of these we can tweak because they know they work. Okay, next slide. Okay, we are here to support you. There are a lot of resources. From the very beginning of this continuum, you can call the emotional support line at 276-3100 with any question that you have about anything, and somebody's going to listen. They're going to support you and help you figure out what direction you need to go. LifeWorks EAP Connections is available to any employee and also anyone in your household. And I always pause there because often people forget about that. So if you're listening to this saying, you know what, generally I'm doing well, there might be someone in your household that's not. They're welcome to call EAP. It's completely outside of the e-record system. It's confidential and it's free. At EAP and BHP, we're doing everything over Zoom unless we have to get somebody in because to protect like imminent harm. And we've only done that like 4 times in the past month. So we can do everything over Zoom or by the phone for EAP. And if the problem is more persistent, so if you're someone in your family is really struggling with anxiety or depression, Behavioral Health Partners is here to support you, and we can see anybody that has the U of R insurance plans. It doesn't matter to me so much who we are or what we do out of these 3. You can call the emotional support line, you can call EAP, or you can even call BHP, and we're going to talk to you and figure out where you need to go. So please just know that we have a lot of different pathways for support that can include short-term support, psychotherapy, and even medication management. Okay.
Thank you so much, Anne. We just have 1 minute, so we have one question here from Steve Brenneman. There was a movie called What the Bleep Do We Know, which the idea here was to have positive thoughts in the morning before going to work. And the question is, how does that interact with the 3 things study, which says to do it before bed?
I would argue from a cognitive behavioral perspective that any time you're taking a moment to align with something positive is going to be really helpful. So we know that from cognitive behavioral therapy, you're realigning with those positive thoughts, and it's certainly not going to hurt. And if it works for you, please do it.
Great. Thank you so much, Anne. Thank you, Mike. This was a great presentation. We do have to end this grand round. So thank you so much for sharing all these insights and tips on maintaining mental health and overall well-being during this challenging time for us all. So many thanks again for putting this presentation on short notice like this. We greatly appreciate joining us this morning for this. Thank you all for attending this session. And again, slides will be shared as well as a recording for this session. Thank you.
Thank you.
Bye-bye.